Thank you for joining us tonight for the Flowonics Pain webinar. We are going to give everybody 2 minutes to log in, and then we will begin the program with our wonderful faculty who's joined us tonight. Again, we're going to give everybody 2 minutes to log in, and then we will begin the program. Thank you all for logging in. We are going to begin the program at 2 minutes after the hour in order to give everybody time to log in. Thank you all for joining us tonight for the Flowonics Pain webinar. We're going to give everybody 1 more minute to log in. Thank you all for joining us tonight. We are going to start the program at 2 minutes after the hour to let everyone log in. Thank you all for joining us. We will now begin the program.
Good evening. Welcome and thank you for attending the first ever Flowonics Pain webinar. Today is the last day of Pain Awareness Month, so I think you'll find tonight's topic of key real-world experiences of recent advancements in targeted drug delivery appropriate and enlightening. My name is Ellen Summerlad Bednar, and I am the Senior Director of Marketing at Flowonics. To start off the evening, I'd like to highlight our panelists and walk you quickly through the agenda. Next. Our special guest speakers this evening are Dr. Anjum Bucks, Dr. Pooja Chopra, and Dr. Navdeep Jassal. Dr. Bucks completed his training in anesthesia and pain management at the University of Kentucky. He has been practicing interventional pain management and been involved in targeted drug for over 15 years with over 300 Flowonics pump implants. He currently is in private practice with 3 offices throughout central Kentucky. Dr. Chopra recently completed her fellowship in pain medicine at MD Anderson in Houston, Texas, and she currently practices at Henry Ford Hospital in Detroit, Michigan. Dr. Jassal completed his fellowship in pain medicine at the University of South Florida in Tampa, Florida, and has been practicing for over 5 years. He is the founder and practices at the Spine and Pain Institute of Florida in Lakeville, Florida. Our Flowonics panelists are Bryson Bratcher, Regional Sales Director South, and Corey Brantley, Senior Field Clinical Engineer. Next slide, thank you. The agenda for this evening is the following. Bryson Bratcher will speak to the current state and focus of Flowonics. Dr. Bucks will speak to the Prometra 2 technology. Dr. Jassal will speak to PAC recommendations for intrathecal pumps. Dr. Chopra will speak to recent clinical studies and data, and we should have about 15 minutes at the end for a Q&A session. Next. Bryson, would you like to go next, please?
Yes, ma'am. Good evening, everybody. Next. First, we'd like to thank everybody, the physicians and the staff, for dealing with the challenges of pain management through the pandemic. Speaking personally, I know it's been a complete change of how you had to practice medicine, how you had to look at it, how you had to address your patients, and we appreciate the effort on behalf of all of us at Flowonics and all of the patients worldwide. The physicians and the company and I felt like it was important to make sure we explained where we are now, where we came from, and where we're going. So as a background, Flowonics is not a new company. We've been around for 15 years. We are extremely well financed, and we plan to be around for years to come. The technology speaks for itself. It's second to none. You're going to learn quite a bit about valve-gated technology during this program. I encourage everybody to look at it objectively, think about how it applies to your practice each and every day. We've implanted thousands of pumps, and many have been implanted for 10 years or longer. As you all know, we are FDA approved for 10 years. Next. Our growth has accelerated drastically just in the 3 years since I've been here. It's my region in particular has grown in a large way. We're continuing to add headcount. We're continuing to add clinical. We're continuing to partner with other companies. If you were to compare Q3 of 2019 with Q3 of 2020, which we are just now closing, we've had roughly 70% in implant growth and over 50% in revenue growth. Our customer service is unparalleled. We focus on nothing but pump. We are adding people daily. I've got 3 interviews just this week for more people to add to the customer service aspect of things. We're increasing our clinical headcount in particular. We feel it's important that the patients have as many people as possible to reach out to and to take some of the burden also off of the physician's offices. We believe in and we are 100% focused on pump therapy. Next. Focus. You have to improve. Our immediate technology improvement, the low energy Bluetooth fix, we submitted the software patch to the FDA. We've gotten a few questions back. We've answered them. That was weeks ago. We are expecting approval on that no later than November of this year. 8 multiple rates and periodic start time. I remember the benefits of that from my days at another company. The submission for that should be finished up and submitted before the end of this year. The FDA has agreed to do most of our submissions in real time, which means they actually move fairly quick. Product development, looking toward the future, what we're going to do, how we're going to be as a company moving forward. We're developing a demo application. It's tablet capable, iPhone capable for physicians, field staff, anybody to be able to show a patient what's going on and or a physician. Next generation products. Corey's on every single one of these programs in terms of helping out. The clinician programmer, new patient therapy controller, and the digital health platform for offices, which all of those are extremely important moving forward into the future. And something everybody asked about, there is a ProMetra 3 on the drawing board. Obviously won't go into much detail on that, but we are looking at ways to advance and continue to improve the pump. There are certain things we should improve. We listen to our physicians. We actually solicit as much questions and feedback as we can get because we want to know what you want, what will improve your practice, how things can move forward, and what makes pump therapy or targeted drug delivery easier for you to apply in your practices, especially as you're trying to get more and more patients off the opiates. That will end me for the night. Anybody that would like to get in touch with me, you can get my information easily. I would like to apologize for the glare off my head. I'll do a better job at that next time. It's all you, Angel.
Thank you, Bryson. No glare off my head. Yeah.
Never apologize for glare off the top of your head, Bryson. Own it.
That was very insightful, especially with over 300 Flowonics pumps in my practice. It's good to know that the company is not only stable, but it's growing. I personally look forward to the technological advances that Flowonics has coming down the pipeline. And I just wanted to let everybody know, with 300 pumps, really, we've never had an issue with coverage of any of our cases. We've never had an issue with coverage of MRI. And I can confidently tell my patients that Flowonics will definitely still be around beyond the life of their pump. To that end, I'd like to go over the technology of the ProMetra 2 pump and the specifications that really make it a superior pump in the space. The Flowonics ProMetra 2 is a valve-gated, pressure-driven pump that delivers medication to the CSF in microboluses, basically increasing spread of the medication throughout the spinal cord. A lot like when we do single shot bolus trials. So this is very analogous to how we trial, and what we've tried to do is mimic this upon implant. Next slide. The ProMetra 2 is 97% accurate throughout the refill cycle. There's no motor in this pump. It has a battery life of up to 10 years. And there's minimal effect on drug delivery by environmental factors such as temperature and altitude. Next slide. More specifically, looking at the accuracy of the ProMetra 2, there's really no variances throughout the refill cycle, as you can tell by the yellow line. Whereas with the peristaltic pump, there are some variances, up to 20% on output of drug, depending on reservoir volume, as you can tell by the blue line. Next slide. Let's take a look at the inner workings of the pump. First off, there is a 20 ml pump and a 40 ml pump available. Both of these are similar in design. There is a propellant, which is really the driving force pressurizing the drug reservoir to 22.5 psi. This basically pushes the drug out of the reservoir through a filter into what is called the precision dosing system, or PDS. Basically, medication goes through the inlet valve into a dosing chamber, which holds about 2 microliters of drug. This chamber is pressurized to 12 psi. Once 2 microliters of drugs accumulates into the dosing chamber, drug is then forced through the outlet valve, through the flow activated valve, out the pump stem, and out the catheter. And it's pushed out the catheter with a forceful exit velocity 6,500 times that of the peristaltic pump. Next slide. Let's look at the flow activated valve. This is certainly an update to the ProMetra 2 pump as it has evolved from the ProMetra 1 pump. To note, the ProMetra 2 pump is MRI conditional up to 1.5 Tesla. Basically, the flow activated valve will deploy in the event of a high flow rate, such as during an MRI, basically shutting off or blocking flow of any drug from the reservoir to the patient. The flow activated valve will only close in the event that both the inlet and outlet valves are open at the same time. So even though the ProMetra 2 pump has this flow activated valve to prevent flow of medication from the reservoir to the patient, Flowonics several years ago took some additional steps to adopt a protocol to ensure patient safety during an MRI, essentially. Next slide. This MRI protocol is for elective MRIs. Basically, prior to entering the MRI environment, the ProMetra 2 pump should be emptied of any drug except in a medical emergency. The patient then undergoes the MRI, and after the MRI, it is confirmed that both the inlet and outlet valve are closed, the pump is then refilled, and then restarted. Next slide. In the event of an emergent MRI, when a pump cannot be emptied, it should be noted that the patient can receive a small amount of drug, usually less than 10 microliters bolus during the MRI. Depending on the concentration of the drug, the physician needs to be aware of how much drug the patient may receive. I've had several patients undergo an emergent MRI safely. This is obviously not an ideal situation, but it needs to be noted that basically the pump stops during the MRI and has to be manually restarted after the MRI. So empty the pump when possible. Again, every clinical specialist for Flowonics is a nurse and can cover MRIs. Also, the home infusion companies like AIS, Basic Home Infusion, and Pentec also have nurses that can help cover MRIs in an on-call situation. So in our practice, we've really never had an issue getting an MRI covered. Next slide. There's been a lot of discussion around safety these days, especially with the recent FDA letter on safety surrounding spinal cord stimulation. So let's talk about safety about the pump. or around the pump. This pump is designed in a teardrop fashion to distinguish the catheter access port or the cap from the refill port. Both ports use different needles, and the refill port is raised so it can be easily identified. There's positive pressure upon accessing the refill port, again 22.5 psi in the refill in the reservoir. So if you've ever accessed it, make sure you have a syringe attached, otherwise drug will shoot across the room. The positive pressure of the 22.5 psi also gives us some reassurance during the refill that the needle is still in the pump, as most pocket fills don't normally occur during the refill as the needle comes out of the pump. So while I'm refilling a pump, usually I push about 5 mLs of drug and let the syringe basically fill up a little bit, and I push 5 at a time to make sure I'm still pushing against this 22.5 psi, making sure all the drug is going in the pump. Also, this refill port is designed to withstand up to 1,000 punctures. The pump stem and catheter connection site is also very flexible, reducing any stress at this connection. And there's a sutureless connection, which simplifies the process for attaching the catheter, which goes right on that stem, and minimizes any potential for a compromised connection. Next slide. So here are the numbers. Here are the numbers of safety. There's been no reported pocket fills. There's been 1 reported granuloma, and the pump doesn't have a motor, so obviously no motor stalls. Next slide. Here's the patient programmer. Again, this patient programmer has undergone some evolution over the last 3 years since I've been using it. It now contains the novel dosing algorithms, which Dr. Jassel will cover in his section. It's also very user-friendly. It's touch screen. It walks you through every step and confirms each step before you program. So it's very easy to program and very intuitive. Next slide. This is the patient therapy controller. Again, boluses are set by the physician. It's important to note that the boluses are on a 24-hour clock starting when the patient receives their first bolus or when they first press it to give themselves a bolus. It communicates with the pump wirelessly. Also, it has a rechargeable battery, much like the cell phone. Also important, as you can see, it has date of next refill. It automatically adjusts the refill date every time you give yourself a bolus, and it's displayed after every bolus, depending on how many boluses have been used. So the patient actually knows when their refill date for their pump should be, or when they're going to run out of medication. So we have a lot of patients call our clinic when they haven't used a lot of their boluses, and they can push their refill date out because they have enough medication in their pump. Also, when you're programming these PTCs or patient therapy controllers, it needs to be present to make any changes to it. So whenever you have a patient with the PTC, make sure they bring it every visit in case you're going to make any changes to the dosing of the PTC. Next slide. Looking at the delivery of drug from the ProMetra 2, Andreas Lindinger from the University of Chicago has done a lot of work with Flowonics, kind of modeling the spine and disbursement of drug in the CSF. As you can see from these slides, over the course of 8 minutes with the ProMetra 2 pump compared to the peristaltic pump, there is greater drug dispersion throughout the spinal cord with this increased exit velocity. Next slide. Also, there's less concentration of drug around the tip of the catheter, basically lessening the risk of developing a granuloma. Next slide. Finally, here's the updated interrogation report after you program a pump. Again, this has evolved over the last couple of years based on physician input. As Bryson said, since I've been working with the company for the last 3 years, they've always sought out physician input, and this is one of the things that we wanted to change. All of the changes that we make to the pump are highlighted, and the pre and before and after interrogations are side by side, so we can see kind of before the interrogation and after changes are made, which makes it for easy reference. And now I'm going to turn it back over to Ellen. Thank you very much.
Thank you so much, Dr. Bucks. I really appreciate that. I do have some questions for you, please. How do you handle MRI for your patients, and is it a burden to you and your staff?
Certainly. It's a great question. And that's been one of the things that people have always had an issue with the Flowonix pump. But usually it's been easy for us. After implant, we basically tell the patients to call our office whenever they have an MRI scheduled. Also, a lot of these patients also call the Flowonix representatives or clinical specialist. Once they call our office staff will notify the clinical specialist, and this Flowonix clinical specialist or one of the nurses from AIS or one of the home infusion companies will meet the patient at the MRI center to access the pump and take out the medication before the MRI and refill and restart the pump after the MRI. So really, it's been no burden on our office staff. It's one phone call, and we contact the clinical specialist, and that's it. So it's been very easy with no problems.
Great. Thank you so much for that. And one more question, please. What do you think are the biggest safety features of the Flowonix ProMetra 2 system?
I think one of the biggest things that I noticed is refilling the pump. I feel safe that I'm actually in the pump, and no fear of having a pocket fill. The raised refill septum makes it easy to feel. Also, it's pressurized to 22.5 psi. So you basically, once you access the pump, all the old drug or leftover drug in the reservoir automatically fills into your syringe. And then when you're filling new drug, you're pushing against this 22.5 psi. So you're assured that you certainly are in the pump and not in the pocket every time you refill the pump. The other safety feature, which I found, is you can certainly stop the pump if you needed to for whatever reason. And there's been a couple instances when we've had patients that may have come in over medicated for whatever reason, or have had some issues. And we've been able to stop the pump, and that's been an important thing for us. The programming has certainly been very safe, as evidenced by the interrogation sheet. All changes are highlighted, and also the before and after being side by side for reference is very important. We've caught some errors in programming just by having these changes highlighted and having the before and after side by side. So there's been a lot of safety features. Again, the refill, the pressurization in the reservoir, the fact that you can stop the pump, and certainly interrogation are probably three things that I would highlight.
Great. I really appreciate that answer, Dr. Bucks. Thanks again for your presentation. And now I'd like to invite Dr. Jassel to go over your part of the presentation, please.
Thank you so much. What incredible content, of course, by Dr. Bucks. He has been an incredible mentor, certainly someone that I've learned a tremendous amount and keep continuing to learn a lot about from intrathecal pumps. So let's dive right in. So he's done a very great job of setting the framework in terms of what a pump mechanics really entails with this novel type of pump. But let's push forward, and I'm going to talk a little bit about intrathecal therapy and some of the novel dosing strategies to a Flowonix pump with the ProMetra 2. But before we do that, I think it's important to start going over some of the evidence-based guidelines from the Polyanalytic Consensus Committee that were revised in 2017 by a dear colleague and mentor of mine, Dr. Deer. And I think it's important to mention that recommendations, one of the most important recommendation in my eyes, is that IT therapy is not considered salvage therapy. In fact, It's not considered salvage therapy after failure of systemic high-dose opioid-based medications. And I think that is first and foremost. Number two is that compared to systemic opioid delivery, IT therapy appears to be safer based on mortality and morbidity data, and there are fewer diversion risks. And I think this is very important to highlight. Next slide, please. With that being said, I think it's important to differentiate some of the pump mechanics and go a little bit more in detail about of how the inner workings of this pump works, and then let's relate it to clinical practice. So looking at the above part of the slide, there's a simple continuous infusion pump. At the lower part, we're going to talk about the design pattern of the Prometra 2 and how it relates to a constant flow pattern. So the same delivery dose is being administered throughout the day. It's 1 milligram per day in both pumps on the top and the bottom, but they're being delivered in a different way. And Dr. Bucks had mentioned earlier that there is a design to this pump because it's valve gated. There is a way that you can turn off the pump, but also between the delivery of boluses being given, even in constant flow, there's absolutely no flow between the boluses. So notice that there is a drip pattern in a simple continuous infusion pump, but the difference between that and a constant flow pump that we're going to talk about with Flowonics is that the medication is given in a series of boluses with no flow between the boluses. And I think this is important to mention because this allows for lower dosing strategy for your patients with in my opinion, better analgesic response for your patients long-term with lower dosing strategies. Next slide, please. So specifically with this pump, which is unique to this pump, is that there are novel dosing algorithms, and this is called periodic flow. And periodic flow is going to deliver medication in a very specific sequence of periodic infusions with no flow in between. And this can be personalized to the patient in many different ways for any unique pain distribution or pain that waxes and wanes for a patient. I think even though this is for malignant and non-malignant chronic pain, this can also be utilized very effectively even for our spasticity patients when delivering intrathecal baclofen. So let's not forget about that. The medication dose, the time over which the dose is delivered, the duration and the period can be very personalized and programmed by the clinician for the patient. Again, noting that there's no flow, absolutely no flow in between each of the delivered periodic doses of medication. Next slide, please. This is a comparison now with the same type of pump, the Flowonics pump, again, valve-gated pump showing the constant flow that we showed earlier in the lower part of the slide, but this time now this is going to compare a periodic flow pattern. So again, 1 milligram per day that's delivered for the pump, and showing again no flow in between these 2 microliter boluses, comparing it to the lower part. In this unique flow pattern, the periodic flow was set to 6 sets of 8 microliter boluses and a total of 50 microliter boluses per day. So 1 minute every 4 hours, again, no flow in between each of the boluses. Unique to this pump, same amount of doses delivered for this particular patient in the course of the day, but again, it's showing the periodic flow pattern. So very unique to this pump, but I think it's important to mention because I will mention at the end from my own personal experiences as well as experiences, whether it's retrospective studies or whether it's case studies, that this will allow for lower dosing strategies with improved analgesic over a long period of time for our patients. Next slide, please. So let's talk a little bit about the evidence. So this slide is busy, but I think if we're going to focus on it, this is a single center retrospective analysis of 40 patients evaluated over the course of 3, 6, 12, and 24 months post implants. And really the bulk of this data is going to show that after a 24-month period via a valve-gated drug infusion system, the data demonstrated that there was over a 2-fold and a 20-fold % decrease in the use of bupivacaine and hydromorphone, and a 24% lower average dosage of morphine delivered. The data is actually going to reflect 1/3 of the dose escalation seen as compared with the peristaltic pumps at 24 months post de novo implant. So if you are starting a patient on pump therapy, you want not only improved analgesia, but in my eyes, as a solo practitioner, I want to achieve the best possible outcomes with the lowest dosing strategy for my patients. I think this is very important. Next slide, please. This slide is going to show a retrospective review from 2 independent centers examining medication use and pain relief in revision patients now. So patients that were initially implanted with a peristaltic pump, but now later revived to a valve-gated pump. And this is going to look again at 3, 6, 12, and 24 months post-implant, with the comparison after the end of the titration period. So the data is going to reflect in this case that there's equal or better pain relief at 20 to 30% less dosage following the replacement with the older peristaltic pumps with this valve-gated pump, again showing improved efficacy with lower dosing strategies. Next slide, please. This slide is going to show specifically a case study by Dr. Chopra and Dr. Bucks, who are going to be speaking today, showing that there was an IPG exchange from a peristaltic pump to a positive pressure valve-gated pump. And this particular patient was going to be was using zinconitide. As we know, zinconitide has great efficacy for our patients for both malignant and non-malignant pain, both neuropathic and nociceptive, but it has a very unique narrow therapeutic window. So it's very important to remain dosage that is quite accurate with these patients. When revising these patients, when decreasing even 10%, the patient exhibited some symptoms. The dosage had to be reduced some more. So overall, the dosage was reduced by nearly 40%, again, resolving the adverse effects, keeping them in their therapeutic window for the patient, but continuing to provide adequate analgesic relief at 80 to 90%, showing again, low dosing and more exact precision to the pump compared to the peristaltic pump. Next slide, please. This data is going to show periodic bolusing with no basal rates is going to yield minimal dosing escalations while yielding a 20% reduction in VAS as well. So again, comparing now periodic dosing as compared to continuous flow. Next slide, please. Next slide. I'm going to finish off at least in some of the content with this, with Dr. Chopra again and Dr. Bucks showing the reduced intrathecal medication requirements when switching intrathecal pump settings from continuous infusion to intermittent boluses. So same pump, but switching the continuous to now this periodic flow. And this, next slide, it's going to show adverse effects even despite 20% reduction in his daily dose of concentration, but improved analgesic relief with lower dosing medication using periodic flow. So that was what was shown in these little bullet points. So I think it's important now to mention intrathecal bolus trialing. And again, these comes from the PAC guidelines. In the later slides, I just want you to remember things like the fentanyl dosing, and the morphine dosing, the zinconitide dosing. This is great for showing and looking over, even if you're starting to trial with pump. But the main point of the PAC guidelines showed that there was no difference in terms of trialing these pump patients, whether it's single shot versus duration of a catheter trial. Next slide. And I think this is important to mention because you can really mimic your intrathecal single shot bolus trial if that is what you are administering with this type of pump design. You can almost have a very similar type of implanting effect or therapeutic effect, even with lower dosing strategies, once you've put the catheter at the right location compared to your single shot trials. Again, this is starting dosage ranges, and I want you to look at the morphine and fentanyl because this is going to become important in some of the later slides from my own clinical experiences. Next slide. Maximum concentrations, I think, were a very important thing from PAC guidelines. It really cut the reduced impact of catheter tip granulomas, but also with this unique delivery system of the pump with high velocity flow pattern with the valve gated design. It's also going to decrease the amount of granuloma tip formations, and that's something Dr. Bucks had mentioned earlier. From a safety and efficacy point of view, just really highlight some of the characteristics of this unique type of pump design. Next slide. I'm going to finish off by mentioning 2 patient case scenarios. I think this is probably the most important content from the delivery that I'll deliver tonight, because this will really highlight some of the novel dosing patterns, specifically periodic flow, and how it's impacted my patients in a very unique way. So here's one patient, traditional L5S1 fusion, unfortunately not having pain relief with a traditional spinal cord stimulator, a paddle that was implanted in the past. Of course, the patient had tried multiple types of opioids, non-opioid based medications. We tried to reprogram the device, and we tried to utilize some of the therapies that were great for this particular patient that were implanted by another physician. Unfortunately, it didn't work. We developed a PO weaning program for some of his chronic oral medications, which I would recommend. We trialed the patient with intrathecal zinconitide for their chronic non-malignant pain. Unfortunately, did not work, but we trialed them with a single shot bolus of morphine at 0.2 milligrams in 2 milliliters. Did fantastic. The patient was implanted at T910 for their axial low back pain, and currently, more than a year out, the patient still maintains about 80 to 90% adequate analgesia with no oral medications, simply delivering 0.1 milligrams of morphine, periodic flow every 6 hours over a 5-minute period. So again, the patient's getting adequate analgesia with a total of 0.4 milligrams. So this is, again, showing very low dose strategies with the morphine, sometimes even the same type of dosing that you would administer to a trial type of patient more than a year out. Next slide. I'm going to end off with something that is very similar for another type of patient, 73-year-old female with a history of L1 to S1 fusion. Underwent a paddle implantation by another neurosurgeon. Unfortunately, it was complicated with the spinal cord infarct. Presented to my practice with severe neuropathic pain on very high dose oral opioids as well as transdermal opioids. And the patient had tried multiple medications. The MRI thoracic spine that I did prior to implanting the pump showed arachnoiditis or clumping of the nerve roots at T12. The patient had an oral and a transdermal weaning in my traditional pattern that I do in my practice. I trialed her with intrathecal fentanyl, 40 micrograms, of course, off-label, but still line 1B for non-malignant chronic pain on the PAC guidelines, implanted at T12, and currently she's utilizing periodic flow, 1 bolus dose given every hour over 5 minutes, 24 times total per the day at 0.5 micrograms. That's a total of 12 micrograms per the day that she's delivering with fentanyl, lower than the amount that she received in the trial dose single shot with adequate analgesia, again, off of all oral and transdermal medications more than a year out. So I hope this really delivers some of the messaging in terms of what Dr. Bucks had brought up and how it translates into clinical practice within my practice, and as well as several other retrospective studies and case studies. I'd like to turn it over to, I guess, Ellen at this point. Thank you.
Thank you, Dr. Jassel. I really appreciate that, and particularly the patient examples that you had at the end. In that light, can you tell me how have the ways that you identify patients, your patient selection, changed over time, please?
Yeah, so I think that's a great question. So, over time, I think that even within my own fellowship, and I'd love for Dr. Chopra later to chime in on this, but I know that for my practice, of course, malignant pain is something that it's always high on my radar. I always thought of, post-laminectomy patients or failed back surgery syndrome patients who've maybe even failed spinal cord stimulations. But I think to broaden my horizons, we really should think of other set diagnoses. So PAC guidelines wise, other examples, patients with multiple compression fractures, spinal stenosis at several levels, multi-level spondylosis, not conducive to surgical intervention, abdominal pelvic pain, think about your visceral somatic type of pain for your patients, extremity pain such as complex regional pain syndrome. I think intrathecal zinc conatite is a fantastic choice for these patients that may have not done well with traditional DRG or spinal cord stimulation. Post-thoracotomy pain. These are some of the many patients that you can really deliver adequate analgesia. And please do not forget your older patients who have done poorly with intolerable side effects with systemic oral opioids. So I think that those are some that I really think about now in my practice before I give up on patients or say there's nothing I can do for you.
Thank you so much. That was very insightful. Another question I have, please, are what are the steps that you take when inheriting pump patients from other physicians?
So I've gone about 1 minute over, so I'm going to make this one very quick. And I think really what it comes down to is really get a chance to review your records with your patient, take a thorough history and physical examination, interrogate the pump. Feel free to do any sort of investigative studies if you feel like the catheter is not in the right location. Whether it's imaging or whether it's a catheter diet study, and discuss it with your patient. You may or may not accept the current dosing that they're at. Try to figure out what the dosing means for the patient and some of their analgesic response, and then go from there. So I try to keep an open mind, but I think definitely reviewing what the patients had in terms of what was in their pump prior to them coming to my practice, and me reviewing their H&P, I think is very important.
Thank you so much. I appreciate that answer.
Thank you so much.
So now I'd like to turn it over to Dr. Chopra, please, related to the recent clinical studies and data.
Thank you so much, Ellen. Wow, Dr. Bucks and Dr. Jassel have done such an amazing job. They're actually both my mentors, so I have learned so much from them over the years. So I'm going to transition over to talking about pivotal studies. So the 3 pivotal studies that are currently ongoing are the transit study, for which Dr. Bucks is actually PI. And the objective for the study is to demonstrate that a reduced dose of medication that's delivered through a newly implanted ProMitra 2 pump will have either the same or an improved VAS score compared to the baseline dose of the same medication delivered through a peristaltic pump. And this is being assessed through ODI as well as global pain scale assessments. And anecdotally, we've noticed an approximate 20% dose reduction from the baseline dose. Since as we initially started, we trialed less than 20% reduction, but we had many patients present complaining of dose-related side effects, and we actually ended up writing those up as case reports, as Dr. Jassel previously presented. Next slide. So the PROSPER multicenter study, which Dr. Jason Pope is the PI, the objective is to assess the efficacy as well as the opioid-related side effects, comparing, this is for intrathecal therapy versus conservative medical management. And this is being assessed through the PROMISE 29. And the study is unique in that it also is comparing the cost effectiveness between the 2 treatment groups. And in order to participate in this study, patients need to have undergone a successful psych evaluation as well as a successful intrathecal trial. And unfortunately, at this time, patients who have a spinal cord stimulator implanted would actually be excluded from the study. However, if they underwent a spinal cord stim trial, they actually can still participate. Next slide. And lastly, we have the Evolve intrathecal intrathecal baclofen multicenter study. And this is similar to the transit study, except that the focus is on spasticity as opposed to pain control. And the objective for this study is to evaluate that a reduced dose of baclofen delivered through a newly implanted Promitra 2 pump will result in either the same or improved modified Ashworth scores compared to the baseline dose of the same medication delivered through a peristaltic pump. And this is being assessed through patient assessment scores. And that pretty much sums up the 3 pivotal studies that are currently actually ongoing.
Thank you so much, Dr. Chopra. I'd like to ask you some questions as well. I really appreciate the insights that you gave about the studies. Can you speak to the question of why are intrathecal pumps important, please?
Absolutely. So I've realized that there's a clear role for intrathecal therapies with patients with chronic pain with either non-malignant or malignant etiologies. Training at MD Anderson, I had the opportunity to experience firsthand the role that intrathecal therapies play in the cancer pain population. And it not only ensures a better quality of life as well as functionality, but it also allows patients to participate more in therapy. And we've also seen a positive impact with the cost of care as well as healthcare utilization. And quite frankly, intrathecal therapy is just a lot safer than oral opioids. And it also is associated with less risk of diversion, which is extremely important. And it allows for either a reduction or even discontinuation of oral opioids as patients come in after their implants stating that their pain is just better controlled.
Thank you, that's really helpful. A follow-up to that I'd like to ask you is, how would you say one can incorporate pumps into his or her practice, particularly as you yourself are a recent fellowship graduate, please?
Yeah, that's a great question. So the key is actually identifying the right patient. To be considered for this particular therapy, patients need to have chronic intractable pain that's refractory to conservative or other less invasive pain procedures. And we've actually seen patients that have axial neck and low back pain, patients with failed back surgery, or even patients with pain secondary to malignant etiologies. They've done extremely well with this therapy.
Great, thank you so much. That concludes the last part of the presentation. I'd like to next, please open it up to everyone for Q&A. One thing that I'd like to mention, please, that I think is important, that the Promitra 2 pump is only approved for Infomorph and Baclofen. Just want to make that very clear. And there are some questions that have come in during this presentation. So I'd like to start off with the first one directed at Navdeep because, or excuse me, Dr. Jassel, because Dr. Chopra just went over this. How has your view of pump therapy changed since fellowship, please?
Yeah, I mentioned this earlier. I think broadly, I'm a little bit more aware of when to offer pump therapy to my patients earlier in the algorithm. I think I've done the same, and I think most people can say the same about other neuromodulation therapies, just like they would with spinal cord stimulation, DRG, and PNS. But I think we really should not forget about intrathecal therapy. I think it is a life-changing therapy. It should be offered earlier in the algorithm to our patients. Again, not showing that it should be salvage therapy. It's a PAC guideline, but it's something that really should be initiated earlier in the algorithm for our patients that need it.
Thank you so much.
One thing I'd like to add to that, I feel like Trump interrupting tonight, but Dr. Jassel and Dr. Chopra are much younger than I am. But one thing I've noticed as I've been doing pump therapy for so long, longevity. If I ask any of my patients, they come in, they say, you know what, I feel like my pump's not working. this is a reversible therapy. You can always turn it off, take it out. You always offer that to them. None of these patients want their pump out. They say, "Oh no, it's working, it's working." So patients really, it's changed their lives. They really continue to keep their pump therapy as an adjunct, even to some of the other injections or other things that we're doing. I've also got several patients with both a pump and a spinal cord stimulator as their disease has progressed. So I think pump therapy is certainly a therapy that a patient will keep for the rest of their life.
Thank you for that, Dr. Bucks. Another question that came in, can someone speak please to the protocol or the process for offices that elect to handle the emptying and refill of the pump in the office for MRI?
So, and I think I talked a little bit about that in our presentation on our questions, but, as far as our protocol, the patients call our office and we call the rep, and either the clinical specialist or one of the nurses from AIS meets the patients at the MRI center, or if it's during the day and the patient is getting an MRI in the hospital, we have them come up to the clinic and have the pump emptied and drug kept and in the safe, and then refill as soon as the MRI is done. So.
I'd like to also add that for most of our patients with MRIs, they're obviously considered elective. So they'll let me know about it, and we'll usually actually schedule the elective MRI based on their next refill as well. So if it's possible, that's often sometimes really feasible for the patient as well. So I feel like it doesn't happen very often, but if it does, it can be worked around.
Thank you so much. In the last couple of months, I think this is a really important question to ask of you panelists, please. Are there major differences to implanting the Flowonix pump versus the Medtronic pump?
So no, actually, the short answer to that is no. When I transitioned from implanting Medtronic pumps to Flowonix, there certainly is a learning curve. The catheter that we use is much like the old Endura catheter by Medtronic, and it's the sutureless connector really makes it very easy to connect the catheter to the pump. The pumps are relatively about the same size. There is a suture ring around the pump where you can certainly suture it to the fascia, which makes it very easy. If you put the pump side by side, it may feel like the Flowonix pump is a little bit bulkier, but really there's no real difference in size. So for me, there was really no real significant difference.
Okay, thank you so much. And related to that, for implants, how do you position your patients and where do you implant?
I can take some of that question. So, a lot of times it really depends on patient body habitus. From a typical type, I usually try to put them in a lateral decubitus position. I know in my particular surgery center, they prefer some of the patients to be with general anesthesia. So it allows for a very easy placement if the patient is placed in a lateral decubitus position. Some things to note: if you're placing them in a lateral decubitus position, try to put them as far back on the table so that it's very easy to place the catheter in one swoop fashion all the way from the posterior incision to the other side of the incision to the belly. If you wanted to, there are several physicians that place it in the posterior back, just similar to what they would for a spinal cord stimulator. Again, looking at tissue size, examining, making sure that it's proper placement for the patient. There are some physicians that place it in the posterior buttock as well. So really it depends on the particular patient. I had a cancer patient who was cachectic that we recently wrote up, who was placed in the breast wall tissue as well for malignant pain. So, and that was accepted into pain medicine. So you have to really talk to the patient, talk to them, decide on the patient, making sure that there's no potential chance for erosion.
And I agree with that. Most of my patients I implant in the back. It's very easy to do. It's much like the spinal cord stimulator. I've had less complaints from patients since I've been implanting in the back. One of the things I do is I take a model of the pump and kind of tape it to the patient in the pre-op area where I'm going to implant the pump. So I have them sit, I have them lie down, so at least they know what it's going to feel like and where it's going to be. So, but most of our patients, we certainly have them in the prone position, implant it in the back, and it makes it for a very easy implant.
I agree with both of them. I initially started in the lateral decubitus position, but after speaking with Dr. Bucks, he convinced me to trial the prone technique, and I've been doing what he's been doing from a pre-op standpoint, and I found it very beneficial as well.
Great, thank you so much, everyone. I have a question that's come in the chat box. That is, do you replace the catheter when converting a prior Medtronic pump patient to a Flowonix pain pump patient? And then when you do replace the catheter, do you remove the old one or do you leave it, please?
That's a great question. As part of the transit study, being PI for the transit study, certainly that was brought up on patients that were enrolling in the study. Certainly, I think that when I go from an end-of-life Medtronic pump to a Flowonix pump, or changing any pump, really, I want to make sure that the catheter is patent, it's in the proper position, and it's working. So we usually do a catheter dye study before we change out these pumps to make sure that the catheter is okay. A lot of times I would not change the catheter if I'm able to withdraw CSF and the catheter is patent and in the proper position. Recently, though, I have started changing out all of my catheters, and the reason is those patients that I did not previously change out, I would have to come back 6 months or a year later and change out the catheter because they're having a problem. Most of these patients have had their pumps for 7 years or 14 years, so these catheters are 7 to 14 years old. Over time, they tend to erode, develop fractures. So it's been an issue. So now whenever I change out a pump, I certainly change out the catheter and the whole system. So now I'm dealing with a brand new system and know that the catheter is not an issue. As far as the old catheter, I usually tie it off. Unless I'm taking a pump out for infection, I will usually leave the old catheter in place. I'll tie it off in the pocket because this catheter that's been in for 7 to 14 years, it certainly will kind of leave a hole in the dura where you'll have a persistent CSF leak, and you may have to get neurosurgery to go in and close up that hole. So that certainly could be an issue. So if it's not infected, I just tie the catheter off, leave it in place.
I absolutely agree, especially that last comment, Dr. Bucks. I wish I had heard about that after I graduated fellowship, and I certainly made a mistake once, and I've learned from that.
One more question that's just come in. I think with the time we can get this one in, please. And I think Dr. Chopper, you mentioned SCS. So have you used an intrathecal pump and SCS concomitantly for a patient who still experiences mechanical pain or who has a mixed pain pattern?
That's a great question. So I've seen, just in my experience, there's been patients that for whatever reason they have a spinal cord stimulator, and over time, for whatever reason, either they just have decreased efficacy, and either that or the patient has a more recent spinal cord stimulator placed, and they either develop more of a mixed pain pattern. And for those reasons, I actually have been in that situation where we, in addition to spinal cord stimulation, we actually have been utilizing intrathecal therapy. And in all the case scenarios where I've been involved, I've noticed that the patients actually have gotten really good pain relief.
Does anyone else have any comments or suggestions? We're at the top of the hour now, so I just want to open it up to the whole panel. If there's any other comments that you'd like to make, please.
I would also agree with Dr. Chopra on that. You know, you as much as we'd love to think that everything can be controlled with spinal cord stimulation, you'll have patients with mechanical pain, and you know, mechanical pain is definitely treatable long-term with intrathecal therapy. And so, you know, as much as we'd love to try to revise that spinal cord stimulator with a different type of burst pattern or high frequency pattern or DRG, really just think about the long-term efficacy for intrathecal therapy for mechanical pain.
Just want to add, like Bryson said at the beginning, you know, we certainly believe that the technology that Flowonix has benefits our patients, and I certainly think it's a technologically superior product. You know, my patients have done very well with it. Again, Flowonix is a pump-only company. In the 3 years that I've been working with them, I've seen changes based on my input and other physicians' input, and it continues to evolve. So I'm excited for the future of Flowonix. I'm excited to see the new changes that are coming up. And again, you need to try it for your patients to see if it's something that will work for your patients in your practice.
Great, thank you so much, Dr. Bucks, and thank you so much for agreeing to do this presentation. I think it's been extraordinarily helpful for our physician customers. Thank you, Dr. Chopra. Thank you, Dr. Jassel, and thank you to Corey and Bryson for being on the call as well from Flowonix. We appreciate you, the audience, everyone who's been on this webinar tonight. Thank you for your time out of your evening, and we look forward to seeing you at the next one.
Thank you.
Thank you.